Hi, good evening, everyone. My name is Yawei Song. I'm the project manager with the Community Outreach and Engagement team at the Sidney Kimmel Cancer Center. It is my distinct honor to welcome you to join tonight's Facebook Live event, conversation about cancer, recovery, research, and reducing your risk. Our topic tonight is going to be focused on breast cancer, and we will cover information on breast cancer screening, diagnosis, treatment, research, and also a lot of resources for you. And we are joined tonight with our medical experts from the Sidney Kimmel Cancer Center, our community partner from Living Beyond Breast Cancer, and also a breast cancer survivor who is also the champion for community advocacy. As our panel sharing their knowledge and experience, please do not hesitate to ask them questions. You may leave your question on the Facebook comment area, and we will try our best to answer all your questions during this live event. So to start today's session, we would like to first introduce our amazing panel. So could each one of you share a little bit about yourself? Maybe we can start with our doctors, Dr. Nikki.
Hi, everyone. I'm Dr. Nikki Simone. I'm a radiation oncologist here at Jefferson. I am also one of the Cancer Center program leaders and wear a few different hats. But my focus, I think, tonight is talking about research. And I have a basic science lab. We do clinical trials and some health disparities and outreach programs as well. So happy to be here. And thank you, Yahweh, for putting this on for us.
No problem. Dr. Allison Zibelli.
Hi, I'm Dr. Allison Zabelli. I'm an assistant professor of medical oncology at Sidney Kimmel Cancer Center. I mostly do patient care, and I also have some clinical trials running for cancer treatment with chemotherapy and other kinds of medical therapies.
Awesome, welcome. Erin, would you like to introduce yourself?
Yes, good evening, everyone. My name is Erin Allen Hansen, and I am a director of outreach at Living Beyond Breast Cancer. Living Beyond Breast Cancer is a national nonprofit that we're headquartered right outside of Philadelphia in Bala-Cynwyd, but have a national scope. And I'm very excited to be here tonight to share more about our programs and resources for those that have been diagnosed with breast cancer.
Welcome. Bobby, or just go ahead.
Hi, thank you for having me. I'm Roberta Albany, also a breast cancer survivor and also CEO and owner of Cancer in the Know. And I work with various organizations like Living Beyond Breast Cancer as a patient advocate and a volunteer leader.
Awesome, welcome. So thank you so much for joining us tonight. We would like to start our conversation with breast cancer, what it is and how you get screened. Dr. Zibelli, would you like to share with us some background about like breast cancer, like maybe different types of cancer and screening for this disease?
So I'll just start with the basics and what is cancer. So every cell in your body has DNA, and every cell in your body is continuously growing, dying, and replacing itself. And every time a cell replaces itself, it has to copy its DNA. And sometimes that DNA copying goes wrong and leads to cancer. Cancer cells are cells that learn how to do, nasty tricks. They become immortal instead of dying when they're supposed to. They keep living. They grow uncontrollably instead of staying where they're as the size they're supposed to, and they can travel. They go to parts of the body where they don't belong, and that's what causes the trouble. So most breast cancers we find now, luckily, are from screening. And screening is done mostly by mammogram. Unless you're a very high-risk woman, such as a woman that has a breast cancer gene, such as BRCA, we recommend mammograms for screening. And once a year, starting at age 40, is what we recommend now. Sometimes you'll be offered ultrasound as a supplementary screening, which is done with sound waves. And that's usually recommended when women have what's called dense breasts. You might have seen this on your mammogram report. And all that means is your breast has less fat. So it's harder to see things on a mammogram in a dense breast than it is in a fatty breast. Now, if they find something suspicious in your mammogram, they'll usually recommend either a short interval follow-up in like 6 weeks or 6 months to recheck something, or they might recommend a biopsy. But don't be scared if you're asked to come back for more pictures. They frequently miss a spot, usually close to the chest wall, and they want to make sure they can see all the breast tissue. So if they call you back for more pictures, don't be afraid that that means you have something wrong. Most of the time, it's because they need to see a spot that they can't see well on the pictures you already have. So suppose they do see something a little suspicious, the next step is usually a biopsy. And the imaging center will usually set that up for you. And once we know what's, the abnormality is, we can make a treatment plan. But again, I want to emphasize, don't be afraid of a biopsy, because most of the biopsies turn out to be benign, meaning not cancerous. But it's important to find out, because if we find it early, it's much easier to cure a cancer.
Awesome. Thank you for also mentioning or emphasize, like when you get the follow-up phone calls, like for more imaging, it's not saying you're having cancer. I think that is a very important point for the audience to know that. I just want to quickly shift the chair. I just want to ask Bobby, like, would you mind sharing kind of like your experience getting the breast cancer screening, and also like maybe how you find out about your cancer diagnosis?
Sure. I always got my mammograms because I had a partial hysterectomy at age 30. And I was always told I had dense breasts. So in April 2013, I do what I normally do, get my mammogram, and I was told it was normal. Unfortunately, I was having some issues as I was training for my first half marathon with Black Girls Run. And I couldn't remember if I did my self-exam. So I did the self-exam in late October, and unfortunately, I found a lump, and I was like, that lump wasn't there in April. So made an appointment with my GYN doctor. This time around, she did another mammogram, but this time she did an ultrasound. So in November, I had the ultrasound and the mammogram, but unfortunately, the mammogram didn't show the lump. It was the ultrasound. And in December is when I was diagnosed with breast cancer. And at first I was upset about it because I couldn't understand. I didn't even make it to my following year follow-up for a mammogram. How could that be? And I realized that when they told me at 30 that I had very, very dense breasts, no one told me that I should get a MRI or an ultrasound just to be on the safe side. So in April, when I was told I was good to go and then get diagnosed with breast cancer in December of 2013, it's just important that we all should know what our bodies feel like and what it looks like. And yes, get screened for the mammogram, but do your self exams. So that's my takeaway for that.
Okay. Thank you for mentioning the self-exam. And I think Dr. Zibelli, if you can chime in, because I think there are some guideline changes about recommendations, and there's some confusion about like, should I do it? Should I not do it?
So I think Bobby made a very, very important point, and that is that if you find something even if it's between your mammogram screenings, you should tell somebody. Don't wait and see if it goes away. Bring it to somebody's attention, your primary doctor, your gynecologist, whoever can help you. One thing I sometimes see is younger women who find lumps in their breasts and they're told you're too young to have breast cancer. Unfortunately, nobody's too young to have breast cancer. So if you find something in your breast that needs to be pursued, don't let anybody tell you you don't need a mammogram or you don't need an ultrasound, because you need to follow up on these things.
We do have another question for Dr. Zibili. Like, is there anything we could do to help prevent having breast cancer?
So we know that the strongest risk factor for breast cancer is age. The older you are, the more likely you are to get breast cancer. So I could say don't get old, but I don't have a good alternative to that. So unfortunately, you can't modify that one. But eating a healthy diet is important. Eating as many fruits and vegetables as you can. Maintaining a healthy weight if you can. I know that's hard to do in this food toxic world that we live in. And smoking is another risk factor for breast cancer and for many other cancers. So if you smoke, now's the time to quit. Nothing makes me happier than when a patient tells me they quit smoking. There is some evidence that taking hormones for menopause symptoms is linked to increased risk of breast cancer. So if you're going to take hormone supplements after menopause, 2 years is the maximum length of time that you should do it.
I think a follow-up question regarding the screening. Could you be too old to get screening? Like, I think there are people like, oh, I'm in my 80s, like I no longer need screening.
So that's a very interesting question that's getting a lot of discussion in the literature right now. People are saying that you should stop screening at 75 because there's no survival benefit. Well, it really depends on how long are you going to live. If your life expectancy is 10 years or more, then you should still get screened, because I'm seeing plenty of patients who are being diagnosed in their 80s and 90s. And I had a patient who was 101 and was still getting treated. So if you are, if you have a lot of medical problems and, you're a sickly 75-year-old, maybe it makes sense to stop screening. But if you're a healthy 75-year-old or a healthy 80-year-old, you should definitely keep screening. A 65-year-old woman in good health has a really good chance of living to 100. So if you're healthy, you should plan on living to 100.
I love that. Planning to live to 100. We do have another question from the audience, and also just a reminder, if you have questions, feel free to leave them on the Facebook chat. We'll try our best to answer those. The question is, how often should you get a mammogram if you are on average risk for breast cancer?
So average risk women, we're recommending once a year. There's no evidence for benefit for any more frequent than that. Some guidelines are recommending every 2 years for younger women, but there's a lot of controversy. I think the risk is low of getting a mammogram every year. I do it. And Bobby is a perfect example that these cancers can grow fast. So I think once a year is what I recommend.
Okay, thank you. I think as we mentioned about the screening, the diagnose, I think the follow-up is kind of like the treatment options. I know there's also like more advanced treatment options for breast cancer nowadays. Could you give
Mhm.
us like a brief overview of the treatment?
Okay, so it's going to be hard to give a brief overview because there's so many new things in the breast cancer world right now. And a lot of the cancer breakthroughs have been starting in breast cancer first. So it's an exciting time to be an oncologist. But to make it as simple as I can, there's really two kinds of breast cancer. We think about breast cancer as early breast cancer and advanced breast cancer. So early breast cancer is when the tumor is confined to the breast and lymph nodes. We consider women in this group to be curable. So we will put them through a lot of treatment to get to that goal. And then advanced breast cancer is when it's out of the breast. That kind of cancer is not curable, but I tell patients that many of my metastatic breast cancer patients live years to decades. So it's not time to, pick out your gravesite. You could live very good quality of life for many, many years with metastatic breast cancer. So once you know what stage it is, then you have to decide what treatments to get. And that depends a lot on advanced diagnostics. But to put it briefly, we look for certain markers in the breast tumors. And the most important ones are estrogen receptor and progesterone receptor. Those indicate breast cancers that would respond to hormone therapy. And then there's something called HER2, another receptor that responds to targeted drugs that are developed to hit that HER2 receptor. And then the final category is what we call triple negative. These are cancers that don't have estrogen receptor, progesterone receptor, or HER2 receptor. And those women will mostly be treated with chemotherapy. So how do we make the decision about what treatments you'll get from that point? Well, we do that with the results of clinical trials, and Nikki is going to talk about that. Dr. Simone will talk about that more later. And we're constantly doing these trials to find out what the best treatments are. So I'm using the results of clinical trials that came out in May of this year to decide on treatment plans now. So if you have early breast cancer, we're usually going to throw everything at it because we want to cure you. So these women usually get chemotherapy, surgery, and radiation therapy. We have a whole team, and I think we have a great team here at Jefferson, not to plug myself, but it's an awesome team. And we work together to give curative therapy. If you have metastatic breast cancer, I usually try to pick the least toxic therapy I can that will be effective for you, because you're going to be on this treatment for a long time. So I want you to have good quality of life while you're being treated. Because the point of getting treated for cancer is not just to stay alive. It's to stay alive and live a really great life and enjoy your life. So I usually work together with the patient, trying to take her wishes and values into account when I design treatment plans.
Okay. So it sounds like for different patients, they can also get different type of treatment with their breast cancer.
It's almost like every patient gets her own treatment plan that's unique to her.
Yeah. Before I move to Dr. Simone to talk about the research component, how it's like helping cancer patients, I just want to quickly ask Erin to maybe share, if you want to share like about resources for, because I heard this like living beyond breast cancer, right? Like maybe like briefly, what are the resource or the service your organization offers? Like, is there a particular thing you also help patients to have this conversation with their doctors, this bi-directional communication?
Yeah. Hi, I'm happy to. Yes. So Living Beyond Breast Cancer is again, a national nonprofit. We're over 30 years old. And our mission is to connect people to trusted breast cancer information and a community of support. And one of our main kind of core approach is that we understand that there's a lot of different breast cancer, as we were just hearing, is really diverse, and the ways that people want information and want support and to do breast cancer can be really different. And so we as an organization do provide a lot of resources and support, really trying to meet people where they are, to really help them navigate through their journey with breast cancer. So we offer on-demand, emotional, practical, and evidence-based content that's meaningful for those that are just newly diagnosed, just heard those words, you have breast cancer, right? In treatment, post-treatment, but also for those living with metastatic breast cancer. We earlier in this conversation also heard about young women. We have a young women's initiative that is for providing unique services for those that have been diagnosed before age 45. So the best place to learn about our organization is, of course, our website, which is lbbc.org. And there you can find about our upcoming events. So we have conferences and webinars. We also have closed Facebook groups and other areas or ways of connecting with others that are maybe experiencing similar experiences with breast cancer. So we have our Facebook. We have our helpline that is a great place to get peer support, where you can connect to trained volunteers and talk through some of the challenges. And you mentioned healthcare communication with doctors, right? So that's one of the main questions and conversations that are happening on the helpline. What are some questions that I should ask at my next appointment? Things like that. So we do specifically for resources around communications between patients and doctors. There's a lot on our website that really helps patients understand what the diagnosis is, but also how to live with this and what are the practical resources there. We also have created breast cancer worksheets that are kind of one page, great tools to help with that communication. We have one specifically on how to talk to your doctor about sex and intimacy. But we also have preparing for surgery and things like that. So that's a great resource. And again, I mentioned our helpline, and it's a great place to do that too.
That's wonderful. I feel like with the very dedicated clinical team, clinical providers, doctors, nurses taking care of you, and also social service agency like you guys providing that emotional support, additional hand-holding. It's just really nice feeling of like a sense of community that's supporting women go through this journey. I do want to move towards Dr. Nikki Simone, since you're the experts on a lot of the cancer research and studies. Could you just share more about the exciting things that is happening in this realm and how it can maybe benefit the cancer patient? You're on mute. Sorry, Dr. Simone, you're on mute.
After doing this all day from 7:30 this morning, you would think I'd be better at it right now. I think one of the things I really wanted to highlight before I start talking about research and what accomplishments we've had as a breast cancer team in this country is that we are a team, and we're a team from Roberta and Bobby joining labs. I'm going to talk about that in a second, and Erin and Living Beyond Breast Cancer, and trying to help us accomplish some of our research goals. So we are not siloed. We don't just kind of work in our offices and dream up some things, but we really take into account different people's perspectives, and we try to get help to get word out about different things. let me just start by saying that everything that we offer today that is standard of care for our patients was a clinical trial at some point. And so we are literally living on the shoulders of the wonderful women who enrolled in trials when trials, clinical trials was not in vogue. And we have answers to questions from those trials that allow us to now provide what's considered standard of care. So if you probably, remember in the 1950s and 60s, for those of, the standard of care was a mastectomy. If you had breast cancer, you had a mastectomy and that was it. And slowly we started doing a little bit more research and we tried to say, okay, well, can a woman be offered the opportunity to keep her breast and what does that look like? And so the initial clinical trials were really looking at mastectomy as one arm, as standard of care, versus lumpectomy and radiation in the other arm. Chemotherapy was way different at that time. A lot of things were different, but we have the answer to that question, which is both of those treatments are exactly identically equal with regards to local recurrence, distant metastasis, and overall survival. And we can now safely and comfortably tell women that with 30-year prospective data, we can tell you that those treatments are exactly the same. And so it's your choice. It's your choice what you would like to use as your standard of care for local control options. Chemotherapy came along a little after that, where we started looking a little bit more at some agents that can actually help to kill any cells that are in our body. Radiation has vastly changed from a standard huge treatment, really long and intensive with certain side effects, to much shorter, much smaller fields when possible, and really minimizing toxicity. So we're really taking into account the fact that Dr. Zabelli was talking about, that we know that we want to treat you not as the person today, not just to get rid of the cancer, but to make sure that the rest of your life is comfortable. We're keeping, side effects as minimal as possible. So I will talk a little bit about the experience that we've had with Bobby and some other cancer survivors in informing us, and Yahweh, you're doing a lot of this on your side too, is we do take into account voices of patients and perspectives of patients on the research that we're doing. So at Jefferson, we try to work a little bit side by side so that we're getting perspectives from, how was your experience, Bobby? And how did you feel when you were being diagnosed? And are there things that we should be thinking of that we don't? Because in medical school, we are taught to treat, right? And we're so listening to your patients and taking those positions into account. Not only that, but also, having my postdocs listen to Bobby's perspective, some people who don't have clinical training, who are part of the research team, to really listen, so that when they're developing their hypotheses for their experiments, that they're like, oh, what would be great if we can add 4 different toxic agents together and really kill this cancer, but hey, what's it going to do to the patient and the quality of life? And so all of those pieces are really important to work together. So again, what we're offering patients today when you come into the office and I'm having a conversation with you as your clinician is really those standard things were really clinical trials. So it's really important, I think, for all of us to take a second and when a clinical trial is presented to us, to think, could this help not just me? Because some of the trials that we offer are looking at biomarkers or different ways of diagnosing things, but could this help the next generation of patients so that people are living much longer and hopefully we'll be able to cure this disease at some point.
Thank you. I do want to ask Bobby a little bit, kind of like what motivates you to join some of this research? Like, I know sometimes community members do have this maybe like fears or like some misunderstanding or just don't trust about research. Like, what motivates you to join this? And if you want to share a little bit about your experience.
Sure. What motivated me was the fact that Jefferson wanted to understand the issues surrounding clinical trials with regards to the lack of participation in the Black community. And what I will say and have been saying is that the lack of participation is not on the Black community. It's basically on the medical community, because oftentimes we're not asked. So if you start asking us to participate, you will be surprised. We will join. And that partnership with Jefferson, I go in the community, talk about what they are doing in the lab and have them understand what's going on. And as a matter of fact, that was part of my speech this weekend in Chicago about this very thing. What can the medical community do? So at the end of the day, we all need to learn from each other. So it has to be bi-directional. But more importantly, just ask us. Just don't assume because what took place in the past, we're not going to do it. Because, the truth of the matter, we're still having issues, right? And the most current thing is COVID. COVID-19 happened to Black patients and Spanish patients, right? We're the ones, unfortunately, that passed away, and not wanting to take the vaccination, the reluctancy. So if we educate each other and train people like myself to go into the communities and speak about it, and then you all can come in on the backside and as the professionals to educate them, to help them understand whatever fears they may have. But to have us join the trials, we need to be asked. Do not assume anything.
No. And let me just, color that a little bit. So part of what Bobby's talking to us about is we know that our African-American patients and our Black patients have a much higher mortality than our Caucasian patients. And so it's actually a 40% increase in mortality. So there's a lot of stuff that we need to do on the research side to figure out, is there something biological that's within the tumor, some type of molecule that's making that tumor grow that's different in a Black patient than a white patient? But we need to identify, how patients respond to treatments as well. And so it's really important to partner with Bobby and other people to really figure that out. And Bobby knows, the clinical trials at Jefferson, I've had really high success rate with enrolling 50% Black patients on my clinical trials, but it's because I ask every single person that walks in the door, and you have to, really frame things and really explain that we know that there's a disparity, right? Let's call it out. Let's say, okay, there's a problem and we need to fix it. And so we all need to help be part of the solution together. And so Bobby can kind of give her perspective so that the clinicians, that we can all go back and talk to our patients about why it's so important to have representation on clinical trials so that we can really do a better job of treating that disease.
I think we have a follow-up question regarding clinical trials. So does that mean like people will get different treatment during clinical trial and everything will be covered? It's going to be free, or like how they even find out if there is clinical trial and they can participate?
So typically your doctors should be able to talk that through with you. Some, clinical trials are all different flavors. Some of it is we do have patients. I think Dr. Zabelli and I have had a run on young patients lately. And so when you have 20 and 30-year-old patients and they're not going for mammograms, there's an entire cohort of people who are just looking at ways to detect cancer earlier. Can we find this earlier at an earlier stage so that everybody starts off at such a early stage that we can cure this and knock it out of the box? And so some of that is just biomarkers. So there could be somebody approaching you saying, hey, can we take your blood when you come in next time so that we can see if there's a correlate to your cancer outcome and we can then detect cancer earlier. Some of the trials that are offered are just imaging trials saying, hey, we want to see if there's a better way to detect things. Because as Dr. Zabelli, so I'm going to show you an example of a pen here. I don't know if you can see this. All right, this is a regular pen. The top, the little pushy part, that's about 1 centimeter in size. Oh, it's blurring in and out there. I'll put it in front of my face. There we go. So the top part is about 1 centimeter. That's 1 billion cancer cells. And we can see that really well on a mammogram. We can see that really well on ultrasounds. But when you do the pen point, just the tip of the pen, which you can't see in front. All right, it's in front of my face. There you go. Just the pen point, that's about 1 millimeter cubed. And that's 1 million cancer cells. So 1 million cells all huddled together. And guess what? Our detection is not very good. So sometimes people will ask you to join a clinical trial to see if we can find a better way to image things. And maybe it's molecularly targeted, like Dr. Zabelli was saying. Maybe it's a better way to identify where estrogen cells live, and that will draw the doctor to finding a cancer earlier. And so that could be some of the trials. And then some are treatment trials. As Dr. Zabelli said, San Antonio Breast Conference is coming up. We're excited to learn all new things that are really moving the dial on cures and increasing survival. And so we'll look at those things that are going to be presented, and we come back and start changing what we're doing in the clinic right away based on those trials that are presented. And so there are treatment trials. And what about, is it covered? So that's the next piece of this. Most trials are built on standard of care. When somebody opens a clinical trial, they have to do what's called a Medicare billing analysis. So if I want to open a trial, I have to go and say, okay, what part of this is covered? What part isn't covered? We don't want the patient to incur any fees. And so how will we cover that? So the next thing is for the PI, the person who's doing the clinical trial, to go and find a funding source. Oftentimes that looks like a government, like the National Institutes of Health may actually fund a clinical trial to see if we can cover things that way so the patient does not incur fees. Sometimes it's philanthropy, because getting grants these days is very challenging. So sometimes we rely on grateful patients to, in part fund some of those things as well. So hopefully, and that's all when you go through a consent form, when you're going to enroll in a clinical trial, all of that information should be in there, not only what they're going to do, how often things are going to happen to you. So the entire layout of that trial is presented to you all at once. And then the fee situation should also be presented in that.
Got it. Thank you. I think the next question we have is, we may go back in circle a little bit related to like screenings and like resources. I think with clinical trial, and also I think it's relevant with the cancer screening too, there are still a lot of people who do not have health insurance. So for those people, is there options for them?
Yeah. So things like Living Beyond Breast Cancer, Komen, Jefferson, and other bigger institutions make sure that they apply for grant funding for healthy women, so that all women can be offered mammogram. And so there is grant support for those things. You can call the hospital ahead of time and figure out how that would be covered, but there should be an element of that most places would be able to cover for you.
Okay, that's awesome.
Planned Parenthood too, right?
Look for our Dietz and Watson screening
Yes.
van.
Yeah, we do have the mobile cancer screening van. We go out to the community, even beyond the Philadelphia county line. We'll make sure we'll share that resource in our Facebook chat, so you can also take a look. And Erin, do you have any resources you would like to share from Living Beyond Breast Cancer?
Yeah, so Living Beyond Breast Cancer also is really passionate about the role that clinical trials has had and can have on the future of breast cancer treatment. So what we have on our website, which is again lbbc.org, is a lot of information about how to access clinical trials, where to find them, what questions to ask your healthcare team, and what makes a clinical trial, what decisions you should be thinking about there. We also have a really robust blog where we share a lot of people's stories with breast cancer. So some of those blogs are also about participating in clinical trials and what those experiences have been. So there's a lot of resources on our website specific to that. Another thing we do is, you mentioned San Antonio Breast Cancer Symposium, is we also write about any breaking new news that is happening for breast cancer treatment, those practice changing studies that come out. So we do summaries, especially around some of those larger conferences, of what is coming out to really help disseminate what these findings are and how it may impact someone's care.
Okay, that's awesome.
Like one of the trials I have open right now is, collaboration across our Cancer Institute, but it's just looking at the role of diet with radiation. So can diet actually make radiation work better? And we have a trial that's preoperative, and it's actually only 5 days of radiation. So it's for smaller cancers, and we're randomizing patients to diet or no diet to see what the real effect is. So some of them are pretty easy. Obviously, it's a lot of work. It's not that easy to go on a diet, but we do coach you through it and all that stuff. And there are, and we'll have answers by the end of the trial as well.
Great, that's awesome. I don't know, Bobby, have you participated any clinical trial, or if you want to share a little bit more about your either treatment journey or like your thoughts on clinical research or cancer research in general? I know there's many questions from the one.
What I will say, when I was diagnosed back in 2013, my radiologist asked me if I wanted to participate in a clinical trial. And I said yes. And part of it is that he's following early stage breast cancer patients to see if radiation is actually doing what it's supposed to do, because we all know that 30 to 40% of early stage patients unfortunately go on to metastatic disease. So at this point, I'm 9 years out in December, and thus far, it looks like radiation does help. So, along with me being on the Remedex as well. So that's part of my treatment too. But it's important, again, he asked.
Mm-hmm.
He asked, and I said yes.
And having patients be an active participant, right? And figuring out what they want to do, what they can tolerate. And some things are just logistical. It's I can't get 2.5 hours to this center. So what else can I do? Right. And just asking your patient. And asking your patients too. Every woman with breast cancer and men have a busy life, right? You wake up in the morning, you probably have a family you're doing something with, you have to go to work all day. Some people want to go to the gym, and all of a sudden your life changes on a dime and you have to undergo cancer treatment, right? And so it's really a conversation of what's feasible. So here's what I would recommend, but do we need to change that? Like Dr. Zabelli is saying, that everything should be a conversation to figure out what's feasible to make treatment easiest for you.
Thank you. We also have a question from the Facebook asking if there are any research or resources are coming to light for HRT and trans patients.
HRT and trans patients. So we're behind the times with understanding some of the hormone replacement things with our transgender patients. In fact, when we look at the literature, the Scandinavian countries have actually done a much better job at tracking transgender patients and cancer rates than we have at this point. And what we know actually is that hormone replacement therapy, or hormone therapy that people are taking to change the hormone dynamics in a body, they are fraught with an increased cancer risk. And so questions that we have in this country are, okay, when should we start doing mammograms, right? If you're adding estrogen in, at how many years after taking hormones should we be doing mammograms? What's the likelihood that there could be a cancer? It does seem to be that the cancer risk is less than cisgender women, as per the Scandinavian countries, but it's not exactly known yet. This country, we're a little behind, as I said. So we are actually right now, we have our cancer center has a grant to try to figure out really to put into the electronic medical records some identifiers so that we can really start identifying where outcomes are going. So we're really kind of at the beginning stages of figuring that out. We think the cancer risk is a little less, but you should definitely make sure that you're getting your screening. There are some individual institution guidelines suggesting that maybe 10 years after you start hormone therapy that you should start mammograms, but that's a conversation depending on age you start and everything else that you should have with your physician. And we're happy to help with that as well.
Okay, thank you. We have another question related to screening. Are there groups of people who are at higher risk of breast cancer? Also, should men be screened as well?
So I guess I'll take that. The highest risk patients are patients that have, as I said, breast cancer genes like BRCA and the related genes. If you have a strong family history of breast cancer, and we're talking about 2 or more first-degree relatives, meaning mother, grandmother, aunts, nieces, and children, especially if they have breast cancer before the age of 40, you should probably be screened earlier. BRCA positive patients we typically screen with MRI. That's the only group that usually gets MRI screening covered by insurance, because it's, it's expensive and it's kind of oversensitive in the sense that it finds a lot of things that aren't cancer. So unless you're in the really highest risk group, then you should probably not get screened with MRI. The other very high risk group is women who had radiation to the chest, especially in childhood or adolescence, have a much higher risk of breast cancer. So we typically recommend screening them about 10 years after they finish their treatment or age 35.
I think the other question is like, should men also be screened?
Oh yeah, I forgot that. I knew there was a second part and I talked so long that I forgot. So men, we don't recommend screening men because the incidence of breast cancer is so low in men, but it's important to remember that if you feel something, say something.
Mhm.
Because 1 in 400 breast cancer patients is a man. And men with breast cancer are much more likely to have a BRCA gene. So they should be offered genetic testing, and their families should as well.
Awesome. Thank you. We do have a question asking Erin, like, does Living Beyond Breast Cancer offers material in other languages other than English? And if there's any upcoming events or programs they can participate?
Yes, I'm happy to speak about that. So Living Beyond Breast Cancer does have, so we have our website. We also provide printed materials, including guides. We have our guide to understanding breast cancer for early stage, and also a similar guide for those navigating metastatic breast cancer. So we do have some of those guides translated in other languages, including Spanish. And so that you can find more on our website under the guide section there. So that is what we currently have available in other languages. In terms of upcoming programs, we have a really exciting program kicking off this Thursday, the 28th. So that is our Knowledge is Power program, the Black Breast Cancer Experience. And so it's going to be happening virtually every Thursday, the next 3 Thursdays. And it really helps Black patients understand more about their diagnosis, how to advocate for themselves and get the treatment they deserve. And Bobby has been really involved in this project with us. She'll be hosting as part of our advisory group for that, and also hosting an in-person watch party in New Jersey. So maybe Bobby, you want to share more about that, but the website is lbbc.org/power to learn more about that program. We also have Ask the Experts series that happen every couple months, and our metastatic breast cancer conference is going to be back in person in April in Philadelphia. We also will be offering that program virtually as well, but that's one of the largest national conferences on metastatic breast cancer, all for people living with MBC, and it's a really great program. So those are some of the highlights of the kind of live in-person or virtual programs too.
That's awesome. That's wonderful. We're getting close to our planned time. I just want to be mindful with everyone's time too. I do want to hear from everyone on our panel discussion today. What is your call for action or one key message for the audience to take home with them today? Maybe we can start with Bobby.
Well, the call to action would be the medical community ask patients, especially Black patients, to participate in clinical trials, and men and women can get breast cancer, but more importantly, know your body. Do your self monthly exams along with your mammograms.
Thank you. Dr. Simone, I see you're unmute. Maybe I'll just point you.
Yeah. I think the biggest thing right now is COVID's not over, but please come back for your mammograms. There's been a lot of people that have been on hiatus. There has been a little bit more of an increased advanced cancers that have been coming in. So please get your mammograms, wear a mask, we hand sanitize, we sanitize everything. Everything's being wiped down, we promise. Please come in and start your screening. And if offered a clinical trial, I'm going to second what Bobby said. Please think about enrolling, ask all the right questions, make sure it's right for you, but think about it.
So, Erin, would you like to go next?
Yes, happy to. So I guess my take-home message is if you are diagnosed with breast cancer, there's a lot of resources to help you understand the treatments, understand the decision points going through that, and also understand the emotional impact that breast cancer can have on one's life. And there's a lot of support services too. So reach out to the breast cancer community. There's a lot of people that have walked this path before that would love to connect with you, and organizations like Living Beyond Breast Cancer that can help you feel less alone.
That's awesome. Thank you. And Dr. Zibili?
My call to action is cancer will not go away if you ignore it. If you should get screened, and if you find something, please tell somebody. Even if we can't cure you, we can help you. We can help everybody. And we want you to live a long and healthy life, either cured of cancer or living with it. It's not the end of your life. It's there's a lot of great treatments out there, and the treatments are much better than they were 25 years ago when I started as an oncologist. So don't be afraid.
Awesome. Thank you so much. And I just want to quickly mention at Jefferson, we have our mobile cancer screening van that go out to community, provide free mammography for women. We also have program that is available in the hospital that also offers to women who may not have health insurance or have concerns about payment. So definitely feel free to reach out to us. Our Abington colleagues are also having their screening day that's just combined multiple cancer screening into one, and you can have a one-stop shop and get all the cancer screening that you need. So definitely get screened. I think that's my message that for everyone for tonight. And we really appreciate you stayed for tonight's session, and thank you so much for joining us tonight. And this is one of the fourth session we're actually having with the Facebook Live event. Is one of the series on conversation about cancer, recovery, research, and reducing your risk. We'll host many sessions like this in the near future, so please feel free to follow our Facebook for our future events. And if you have additional comments, or if you have additional topics you would like us to cover, please definitely also let us know, or feel free to email us at skccoutreach@jefferson.edu. And thank you again for our amazing panel for your time and sharing your expertise and experience with us. We really appreciate that. Thank you so much.